I'm very, very excited to introduce Dr. Ivy. Dr. Ivy is currently the section head of Pediatric Cardiology and the director of the Pediatric Pulmonary Hypertension Program at the University of Colorado. Dr. Ivy has been treating PH patients since 1994 and has helped run over 20 research trials. He has published over 100 medical articles, primarily focusing on PH in children. So I could not imagine a better person to give this presentation tonight. Thank you so much for your time, Dr. Ivy.
Thank you. So hello, everyone, and I'm glad you all could join us. We had this session 2 years ago, and it was very popular, and I think, what people liked the most was asking questions at the end, so I particularly look forward to that portion of the presentation. So we'll begin with just a very brief overview of pediatric pulmonary hypertension, discuss again in brief how this differs from adult pulmonary hypertension, and then get into some of the evaluation and medications that are used for children, and particularly some of the challenges that we face with pulmonary hypertension medication in children in terms of dosing and in terms of delivery of the medication. And we'll end up just with a few brief words about the sildenafil trial, which has sort of been a hot topic for the last several years with regards to use of sildenafil in children. So to begin with, I'd just like to go begin with what is pulmonary hypertension, how do we define it, and how do we classify it, and are there similarities and differences between adults and children with pulmonary hypertension. So this slide shows the heart and shows the normal pressures in the heart, and this diagram would be applicable for children and adults. So let me see if I can get there's my pointer. So as you remember, the heart has 4 chambers. There's a left upper chamber, a right upper chamber, a left lower, and a right lower chamber. And the blue blood, or less oxygenated blood, comes into the right side of the heart, goes out to the right ventricle, the right pumping chamber, goes out to the lungs, and then becomes more oxygenated, comes back in the pulmonary veins to the left atrium, then the left ventricle, and out to the body. So one of the things you notice very quickly is that normally the pressure on the right side of the heart is lower than the pressure on the left side of the heart. So pressure on the right side of the heart in the right pumping chamber is about 1/4 the pressure in the left side of the heart. And so you can see the filling pressure, the 3 here, is less than the left side, which is normally 8. And the 25 is again about 1/4 of the pressure in the left ventricle, or 100. So when you get out to the lungs, there's a top number, a systolic, a bottom, a diastolic, and a mean or an average pressure. And so the normal average pressure is about 15, and the range of normal is up to probably 18 or 19 so-called millimeters of mercury. And again, this pressure is about 1/5 the pressure in the body. So again, much lower pressures normally on the right side of the heart than on the left side of the heart. So we define pulmonary hypertension by this average pressure in the lungs. And so the diagram is helpful also in that we define pulmonary hypertension by the heart catheterization number and not so much by the echo number. So when we look at echocardiography, again, by looking at the leak of this tricuspid valve, we can get an idea and a pretty good estimate usually of what the pressure in the ventricle is. So this is the systolic number, this 25, but when we talk about definition of pulmonary hypertension, the definition is based on this average pressure, this 15. So when you talk to your physician in the clinic, they may talk to you about the ultrasound, and there you may get a number, a good estimate of the pressure in the ventricle, but the definition is actually based upon the pressure in the lungs. So if we go to the definition, so the definition again is sustained or mean constant elevation of pressure in the lungs, the average pressure, and then that average pressure needs to be greater than 25, and that's in the presence of a normal pulmonary capillary or left atrial pressure. So let's go back to the other side and see, again, this, when we talk about the wedge or the left atrial pressure, that's this pressure, and so that should be, around 8. So if this pressure is really high, say over 15 or 20, for example, that suggests that the main reason for the pulmonary hypertension might be a problem with a valve, here the mitral valve, or the ventricle. And so when we talk about classic pulmonary arterial hypertension, that is the hypertension that's really from the lungs itself, then we have this pressure greater than 25 with a normal filling pressure. And so we can answer some questions later on if there's questions about definitions. And we also look at the filling pressure or the resistance, which is the pressure divided by the flow, and so that's the resistance, and so there's a number for the resistance. So when we classify pulmonary hypertension many years ago, we said there was primary and secondary pulmonary hypertension. And this was back before, in the 1990s. And the reason we did that was we said that primary was idiopathic or unknown, and secondary was everything else. So when the World Health Organization meeting started, very quickly they said, well, we know a lot more than this now, number one. And number two, there's some secondary, quote-unquote, secondary causes which pulmonary hypertension medications can be very beneficial. So then that group changed the classification into these 5 different categories. So one is pulmonary arterial hypertension. One is pulmonary hypertension with left heart disease, and so that's where you'd see that elevated filling pressure greater than 15. Another is lung disease, or diseases that might cause low oxygen. Another is clots in the lungs, or thrombotic or embolic disease. And in children, this is probably extremely rare. And then there's some other causes, and these other causes are from so-called multifactorial or less common disorders. So as this classification was developed further, again, we're not going to go over all this, but you can see that there are 5 different groups. Group 1, Group 2 is the left heart, Group 3 is the lung disease, Group 4 is the thromboembolic or clots, and Group 5 is unclear or multifactorial. So most of the time in children, we see children with so-called idiopathic or heritable pulmonary hypertension. And heritable just means that we know a genetic defect, so we know BMPR2 is abnormal in some patients with heritable pulmonary hypertension, but there are other genes, so-called ALK1 or endocrine, and at the recent World Symposium, there were 2 other genes that were added to the list. One was called caveolin, and one is a potassium channel gene. And so I think these are important because it helps us to know what causes the disease, but maybe even more important, it guides us as researchers and clinicians. If we know there's a gene defect, then we know we need to be able to target that area or research that area to find different therapies. Now, one of the other very common causes of pulmonary hypertension in children is congenital heart disease. And so again, note that idiopathic and congenital are in this group 1. So the medications approved in adults are in this group 1, and we use those medications off-label. But it's important to look for all of these different causes, because the most important, or the best way to treat pulmonary hypertension is to treat any underlying disorder. So again, uncommon in children, but if you had connective tissue disease like lupus or scleroderma, then you obviously want to treat that before just adding a medication. So again, if you had left heart disease, is it possible to treat the left heart disease before considering other medication? Or if you had certain lung disorders, such as, increasingly we're seeing children with so-called bronchopulmonary dysplasia or lung disease of prematurity, that we try to treat all of these things first. So many times in our children, we'll look to see if they have so-called obstructive sleep apnea or nighttime desaturation and need oxygen at night, or some kids need their tonsils removed. And so it's important to try to treat all of these things before we think about medication. So as clinicians, we use this to help think about the different causes, and many times patients don't have just one group or one category. They might have congenital heart disease with some left heart disease, and their tonsils may be big, and those kind of things. So we usually realize that children may have more than one cause of pulmonary hypertension. So this is one of the classifications, and there's another classification that was called the Panama classification, and it was developed because of the unique problems that children have. And so this is an example of a child who has so-called bronchopulmonary dysplasia, who was born early, and you can see here the heart is big, and these white fluffy patches are from some lung disease. So the airways, you can see there's some narrowing of the airways. Down here you can see there's a hole between the top two chambers. Here you can see there's some narrowing of one of the blood vessels that comes back from the lungs. And here you can see a so-called patent ductus arteriosus. So the point of this slide is that many times it's not just one thing that can cause the pulmonary hypertension. There may be multiple causes, and so we need to think about that in coming up with a treatment strategy. So this so-called Venn diagram, where you look at different circles and different causes, so many children would have multiple causes. They might have a growing lung and have needed a ventilator early on. They might have chromosomal abnormalities such as Down syndrome. Their lungs may not be developing normal, or there are other diseases. So again, in children, we need to take all of this into consideration. Now in the past, we really didn't know how many children had pulmonary hypertension compared to adults. And so that's what epidemiology is, to say how often does this happen and how many patients have a certain disorder. So this is some data from the group in the Netherlands, and because all patients in the Netherlands with pulmonary hypertension go to one program, they were able to very accurately look at the so-called incidence, or how many patients with pulmonary hypertension are there. And so what they found is that there are quite a few children with so-called transient pulmonary hypertension, and so these may be newborn babies with what's called persistent pulmonary hypertension of the newborn, or there may be children with congenital heart disease where after you surgically repair them, the pulmonary hypertension goes away. Now, these are more progressive forms down at the bottom, and so again, let's just look at idiopathic, or what was called primary pulmonary hypertension, and you can see that less than 1 in a million children have primary pulmonary hypertension. So, in children we say it's about 0.5 per million, and with adults it's probably a little bit higher. It's maybe 1 or 2. And if there's some kids that have pulmonary hypertension related to congenital heart disease or other causes. So again, most of the time we're dealing with these so-called progressive causes, and the transient causes are usually gone by this point. So how do children present? And so one of the major advances in the last 5 years is we have these large registries. One is called REVEAL, another is TOP, and we can say, well, why do children with pulmonary hypertension present, and how is that different from adults? So the most common cause of presenting symptom in children is shortness of breath. But interestingly, children are much more likely to have to pass out, to have syncope as their cause than adults. So most common is shortness of breath or dyspnea on exertion or difficulty exercising, but children are more likely to present with passing out than they are in children than with adults. So when we look at the diagnosis, again, we need to look at so-called signs and symptoms. A sign is something that we can measure. A symptom is something that we would ask the parents about. So the symptoms, as we said, might be shortness of breath or being tired. Somebody thought the child had asthma, but it wasn't asthma, it was pulmonary hypertension. Sometimes when children pass out, they can have seizures, and so they think it's a seizure disorder, but really it's pulmonary hypertension. So when we look in the clinic, when the doctors look, they see if the neck veins are distended, or if the pulmonary heart sounds are loud, or if there's a so-called gallop or third heart sound. So this is an indicator of heart failure. And when you have heart failure on the right side, then you get a liver that's big, swelling of the feet or the hands or the face or the liver. So these are some of the things that, as physicians we would ask about, and then we would look for each time to say, how is the heart working? If the heart is not working as well, then the liver might be big, or you might hear this so-called gallop, or the face might be puffy, or the hands puffy. So when you come to the clinic, or the nurse is talking to you to see how your child is doing, these are some of the things they might look for. Now, very commonly, an echocardiogram is done, and this is a good test. The nice thing about the echocardiogram is that it's non-invasive, unlike the heart catheterization. So when we do the echo, we look at many different things, and one is if there's a valve leak on the right side, this tricuspid valve, and by knowing how high the velocity is, we can get an estimate of the pressure, and so we look at that leak. We also look at the pulmonary valve, and if that leaks, we can get an idea of the so-called diastolic pressure in the lungs. But sometimes, and maybe 20 or 30% of the time, you don't have a good jet or envelope, so it's not as complete as this, so it's really not very accurate. And when that's the case, we need to look at the shape of the heart. So here you can see the normal round appearance to the left ventricle. You can see, again, I usually describe it as a donut, and the right side of the heart is quite small and sort of sits like a baseball glove around this ball or donut. And when there's pulmonary hypertension, then the right side gets big, and you can see how this so-called septum gets flat because the right side is pushing on this septum, making it flat. So here we can say there's pulmonary hypertension, but we don't know the exact pressure unless we have a good tricuspid regurgitation jet. So as I said, when we look at what are the causes of pulmonary hypertension, we usually start with a good history and ask about, if there's anybody in the family with pulmonary hypertension. Does anybody have lupus? We ask about when was the baby born on time? did they have any lung disease when they were born, and we would do an echo, a chest x-ray, and an EKG, and then really that helps us to evaluate the pressure, but also to look for these congenital heart diseases, the atrial defects, the ventricular defects, other more complicated defects. And in the older child, we want to look and see if there's lung disease. So in a child of, say, 7 years or greater, you can do lung function testing. In the older child, we do sleep studies, and that's what this fancy polysomnography word means. And if we're concerned that there might be so-called airway disease, then we might do a chest CT scan. So again, simplistically, you can think of the lung as blood vessels and airways, and so we need to look at both of those. When we do the lung function test or the polysomnogram or the CT scan, here we were really looking for the airways, and when we do the heart cath or the echo, we're looking at the blood vessels. So again, uncommon that a child would have these clotting disorders or this interstitial lung disease, but we do see it, so we need to think about all of these things. And so we'll get to the heart cath in a minute, but we do a pretty extensive evaluation before starting treatment, because if the main problem was your oxygen level is low at night, and that's what's causing the pulmonary hypertension, and we could treat that just with oxygen at night, certainly I would rather do that than just adding a medication. So we also do some blood tests, and then again to look for connective tissue disease. HIV is uncommonly seen in children with, or as a cause of pulmonary hypertension, clotting disorders or liver disease, or if your child has sickle cell disease, then we know that children can get that. And then over here we talk about the different other tests that we can do. So when we look at treatment, first off, it's really important to know that these medications are not approved for children. They're approved for adults. And we don't, most of the time, we don't have a big clinical trial that tells us this, is the right medicine for your child. So, so we have to say that, sometimes the safety and efficacy and the dosing is not really yet established, and so we go on the best information that we have, and usually that follows on, the adult data. So if you look at the treatments for pulmonary hypertension, back in the 1990s we had very little, just medicines called calcium channel blockers, and then in 1995 IV epoprostenol was approved, and this was really a huge advance because in adults that were not making it, that were not surviving, Flolan or epoprostenol was really life-saving. And we began to use this in children in the 1990s and found that it was very effective, but obviously it's very cumbersome, difficult to do. The parents that have children on Flolan or IV Remodulin or subcutaneous therapies know that this can be a complicated therapy and route, and you have to, sometimes replace the central line, or there can be a break in the line or problems with the pump. So it's complicated, but it can be very, very beneficial. Now, in the early 2000s, bosentan was approved, and shortly thereafter, treprostinil, which was subcutaneous, and then an inhaled drug, iloprost. So in the early 2000s, we began to have other options, and in 2005, different classes of drugs, so sildenafil and ambrisentan were approved, and newer generations of medications were approved, like tadalafil, and then later on different inhaled drugs. And we'll talk about real quick here about some of the newer drugs that were just approved within the last month. So you can see in the early 1990s, we only had one or two, and as today we have 11 different medications that are approved for adults that we use to treat children. So when we look at these medications, there are three broad categories of medication. One is the so-called nitric oxide system, one the prostacyclin system, and one the endothelin system. So the first one approved was this prostacyclin pathway. So you give the medication and stimulates this AC, is called adenylate cyclase and cyclic AMP. So right now we have drugs that can be given IV or subcutaneous or inhaled to target this pathway. The next down the line was the endothelin system, and endothelin constricts blood vessels. So by blocking these receptors, we can treat pulmonary hypertension. And as you may know, there are different receptors and different strategies. One is to block both of these. One is to block only one of them, with the theory that maybe this other one, the ETB, might be beneficial. But it's important to remember that we don't have any good head-to-head trials of these medications, ambrisentan or bosentan, and both of these medications have been beneficial in adults and in children. So we can't really say, as we'll show on the next slide, one is definitely better than the other, but we have some options and some pros and cons. Now, in the mid-2000s, medications that were used for erectile dysfunction began to be used for pulmonary hypertension. And the reason is that it was found that this enzyme, this PDE5, was very high in patients with pulmonary hypertension, and that was preventing vasodilation. So people started studying Viagra, sildenafil, for pulmonary hypertension. So it blocks this enzyme and then increases cyclic GMP, and that's Revatio. And then later on, Cialis or tadalafil was studied, and in that instance, it was a longer-acting drug, but had a similar blocking effect of here on PDE5. Now, one of the drugs that was just approved is called riociguat, and that drug is a little different in that it stimulates this soluble guanylate cyclase and increases cyclic GMP. So broad picture is that we're very fortunate now to have 11 different medications that target these three basic pathways. And as these new drugs have been developed, we've used them in children and learned about them. And one of our jobs as clinicians is to try to be sure that these drugs are first safe. We don't want to harm a child by using a drug, but we certainly want it to be safe and effective. So this slide just sort of goes over those pathways. So these endothelin blockers are, first was bosentan, then ambrisentan, and in the last month, macitentan has been approved. And so now we have three different options. This is twice a day. This is once a day. So there's an advantage on ambrisentan here. But we really have most experience with bosentan in the younger child. So if it's a really young child, we tend to use bosentan instead of ambrisentan. Now when we look at the PDE5 inhibitors, sildenafil and tadalafil, we have most experience with sildenafil and have been using it for over a decade. And we'll talk in a few minutes about, the trial and why the FDA placed a warning. But again, in the very young child, we have a lot of experience with sildenafil and tend to use tadalafil in the older child. Now this new drug, riociguat, over here is in a similar pathway and is very exciting, but for instance, this is why it's really important to understand everything about the drugs. Riociguat might affect the growing bones. So in a very young child, we may not use riociguat. We might use a drug that we have more experience with. So that just points out that, we have to take into consideration that children are growing, and some of these medications, may not be appropriate for very young growing children. Here's the inhaled drugs, so iloprost and treprostinil, pros and cons here. And there are 3 different options now for IV therapy. Epoprostenol, the old standby from the 1990s. Next was treprostinil, and more recently was a room temperature medication called Veletri. So it's important to remember that when we look at these medications in children, we don't have a big trials to say this drug is better than this drug, or this combination of drugs is better or not than the other. We have growing experience with all of these, but it's really an individual decision as to which medication to start with, and also depends on how sick the child is. So this diagram just is a very broad overview, and we do the heart cath. I know that there's not a parent out there or a child that likes or wants a heart cath to be done, but it's very important for us to be sure we know the exact pressure, we're not missing other things that an echo couldn't see, and that we start out with the right medication. So if we do the cath, and you're so-called very reactive, which is not, only about 10% of kids, then you can use a calcium channel blocker. And if your child is in this group, that can be quite effective and beneficial. There are clearly some kids who will need additional therapy, so it's not unexpected that over time a child on a calcium channel blocker might need something else. Well, if your child has heart failure, then we're obviously going to be more aggressive, and there we might recommend that you go straight to an IV therapy because we know that can be life-saving. The majority of children and adults are not reactive to nitric oxide and don't have heart failure, and there we have to sit down and think, well, which is the best medicine to take by mouth or oral? So that could be these endothelin blockers or these PDE5 inhibitors. So usually we would start one of these, then add the other, and then do the inhaled after that. So your child might start on one, and if the child has, more severe illness, they would start on both, and then depending on how they're doing, you might just stay on one, or you might stay on both, or they're getting a little sicker. So we say maybe we could try the inhaled prostacyclin, or if they're even sicker, we would add drugs together and then go to IV therapy. Now finally, if children are failing these medicines, then we can consider opening up a hole between the top 2 chambers, which allows us a pop-off, or there's some kids that just need to go straight to lung transplantation. So when you sit down with your physician, these are the kind of discussions that we have, about is your child reactive at the cath? If yes, we might try this. Do they have heart failure and severe disease? We might go straight to an IV therapy. If they don't, we might start with one and pretty quickly add another, and then consider adding an inhaled or an IV medication. But I think it's important to realize that most kids that we treat that end up in a pulmonary hypertension center are going to be on more than one medication. So it's actually pretty common that our patients would end up on more than one medication. So I'd like to finish just talking about sildenafil for a minute, and sort of the interesting thing about sildenafil, as I said, was we've been using sildenafil for over a decade, and this clinical trial was really, we called it a landmark because I don't think you could do it again. We had patients that were not on any pulmonary hypertension therapy, and they were randomized to no drug or drug, so-called placebo, which we really don't do, true placebo trials if you're not on any medicine anymore. But point here, it took a long time, 5 years, for us to do this trial. And at the end of the trial, we looked at how the older kids could exercise, and the main endpoint or the main results of the trial was that as a group, the children didn't meet statistical significance, but there were some patients at some groups that tended to do better, and some that didn't do quite as well. So the FDA was actually okay with this. They didn't say that it was a very positive trial. What the FDA was concerned about was that when we followed the kids here up to... Are you reusing bottles? I'm sorry? So when we followed the kids for 7 years, we found that those kids that were at the high dose were not doing as well. And so the FDA was concerned about that, and that's really what the warning is about. But I just want to point out, if you look at the kids that were on the low dose, again, this is 100% survival, then the higher up the bar, the better, that those kids on low dose, did very well. 95, 97% of those were alive at 5 years. So I think what we learned is that we shouldn't, we should avoid high doses of sildenafil if possible, and we're having ongoing discussions with the FDA about, how should we use this drug in children. It's not completely prohibited, but there is a strong warning. So with that, I'm going to finish up. Again, I'm sorry we don't have time to go through every medication, but I wanted to be sure there was some time for questions. So I guess we need to ask is, Nicole, how you want to do that?
We can do that a couple of ways. For people who are on the web, you can use the raise hand button if you would like. You can also submit questions through the chat box. Or Dr. Ivy, if you're comfortable with it, we can invite people to just jump in with their questions.
Anything's fine. The only thing I would say is that, since there are other families on the conference, that we don't want to talk about specifics of your child, but more general questions. So please go ahead. All right, if nobody asks, I have people's names up here. I'll start asking you questions. So is Kelly there?
Yes, I'm here.
Hi.
Hello, I'm here. Hi. Okay, so the first question that comes to mind, I guess, is in relation to pulmonary hypertension with congenital heart disease. Is it correct, I think at least this is what we have been told, that because of differential blood flow, it's not possible or very difficult to get a measurement for pulmonary vascular resistance? Is that correct?
So it really, so the question is if you have a patient with a congenital heart defect, sometimes there are holes in the heart called an atrial defect or a ventricular defect or PDA, a connection. And sometimes in congenital heart disease there are other problems. So there can be narrowings out in the lungs. So if there are narrowings out in the lungs, sometimes in association with these other problems, then it can be very difficult to know what the actual resistance is. And the reason for that is if you can imagine if you had some narrowing on one side and not on the other, that you might have more blood to one side than the other. So then it's very hard to calculate the true resistance. So yes, if your child had the type of congenital heart defect where there were extra blood vessels coming into the lung or narrowings in the lung, it can be very difficult to measure the true resistance.
Okay, thank you.
Dr. Ivy, a question has just come in through the chat box. Can you tell me what would be considered a high pressure, meaning too high for heart surgery? When you talk about severe pH, what do you consider severe?
So again, I think this question relates to children with congenital heart disease. And so when we look at children with congenital heart disease, first we need to take them, sort of as individuals and look at all of the so-called associated problems. So before we were saying sometimes there's narrowings in the lungs, sometimes there's extra communications, sometimes there are children that only have one pumping chamber. So it's hard to make a rule that's absolutely acceptable for everybody. So the things that we look at are three things primarily. One is the pressure. The other is the so-called resistance, which is the pressure divided by the flow. And the last one is how much left to right shunting there is. So when we look at the pressure, sometimes the pressure can be high, but the flow's high. And so if you look at that equation of pressure over flow, then that resistance number's low, and then it would be most beneficial for the child to have the surgery. So we like to see, again, this is very, very, very general, not very specific to any child. We'd like to see that the resistance can be below 3 if possible, certainly below 5. We like to see the blood flow to the lungs, this left to right shunt, being twice as much blood going from the lungs or the left side over to the right side. And then the pressure can depend on whether or not the hole is big or not. So, but we would like to see those pressures and flows and the resistance at a low value. So it's really hard to answer that question without knowing more. But one of the numbers is the resistance, and if the resistance is well over 10, then that means surgery is going to definitely be riskier and maybe not an option. So sometimes we would start a medication and then redo the heart cath and see if we can get that resistance number below 5 or higher amount of more flow through the lungs. So I don't know if that answers the question. So you can certainly write down if there's a different question or further clarification.
We have another question that just came in through the chat. It says, I know you haven't talked about this, but have you used IV milrinone in severe heart failure cases due to pH? And if so, how much success have you had with this in your patients feeling better?
So that's a great question. So I think what we would do initially is most of those patients that you might consider an additional IV medicine are also on one of the other IV medicines. And I'm going to go back to my slide real quick here. So before we would start IV milrinone as an outpatient, I think that's what the question is. You would think about, want to be sure the child is on a good dose of either the Flolan or the Veletri or the treprostinil. And then again, most of those kids are also on a combination of other drugs. So in the child that we're really trying to be very aggressive, you would have the patient on one of these IV medicines, usually one of these medicines, and not uncommonly one of these medicines. So you'd have all three. And so if that's not quite enough, we have used an additional IV medicine. Some people like dobutamine, and we have used milrinone more than dobutamine, but again, I think that there's no right or wrong answer there, but I think that that certainly has helped some of our patients to get them out of heart failure. So yes, we have used that several times, and I think it has been beneficial. Now, I would say that if your child is on all of these medications, then obviously the pulmonary hypertension is quite severe, and probably your pulmonary hypertension physician has either talked to you about either the doing the septostomy as a pop-off, or lung transplantation, or even what's called a pot shot, which has been tried more in Europe than in the U.S. But so the answer is yes. We have used milrinone. So another question. I can see them, so I can keep answering. Question is, have you ever known a patient to be on both sildenafil and bosentan and their pH not to improve? What kind of signs would you see if it was improving without having a heart cath performed to check for accurate pressures? So yes, we have seen patients that again, I'm going to put this slide back up, who we started on one medicine like bosentan is an endothelin blocker, and sildenafil, which is a PDE5 inhibitor. It's not uncommon that the children will do well for a while, but that's not enough, and their pulmonary hypertension continues to progress. And so then we would need to go on to another therapy. So that might be trying an inhaled therapy, and it might be, if the child is particularly sick, that we might go straight from combining these two to the IV medicine in addition. So the answer is yes, that we have seen patients on both drugs that their pH doesn't improve. And the things that we look for to try to make our decision, really a lot of it, we'll talk about a lot of different things, but a lot of it is how the child looks and feels and how you feel they're doing. So the things that we look for are, is the child growing? So growth is really a very important, seeing that the children are growing properly is an important part of being sure that we're treating the disease appropriately. Can they go to school every day, or are they home, 1 or 2 days a week? Can they go to the playground? Can they keep up with other kids? How are they eating? Do they, do they sleep a lot? Do they take a lot of naps in the afternoon, very long naps? When they come into the clinic, we would look for those signs of heart failure, and I'll go back to that slide real quick. So in the clinic, we would look for these signs of heart failure. Then we would do the echo, and so if the echo showed some worsening or compression, or that this tricuspid velocity was higher or not getting better, we would think about that. So I think, and then there's some blood tests, for example, the brain natriuretic peptide, the BNPs that we might look at. And so we would look at all of that and then say, is the child, is the disease really progressing in spite of the two drugs? Or, is it stable and sort of low moderate? And then we would sort of look at everything else. Now, our practice in general is that if we're going to make a major change, we do a heart cath. And there's several reasons for that. And again, it's obvious that again, no parent or child likes or wants a heart cath. But the reason is that we need to really know the pressure in the lungs, and we need to know the filling pressure, and sometimes we need to go back and be sure we didn't miss anything. So, I think I would say that most of the time, not all of the time, we would do the heart cath before certainly before adding an IV medication. But is that, it's a recommendation. I don't know that it's absolutely necessary. So another question, are preemies at increased risk for developing PAH as an older child? So we're just beginning to really understand lung disease of prematurity and pulmonary hypertension. More and more, the children that are born very early, instead of being born at 38 to 40 weeks, are born at 23, 24, 25 weeks, are at risk for pulmonary hypertension. So, and the more severe the lung disease, the more likelihood the pulmonary hypertension. So I guess I would answer saying that I think there is an increased risk, but if the child, has come out of the nursery and is, a year old and has no sign of pulmonary hypertension, it's much, much, much less likely they would get it later on. But I think it's important to follow those kids, and we're trying to develop guidelines or rules for, if your kid was born very prematurely, how often should you get an echo? But, many kids who are born prematurely, will do just fine without, if they don't have pulmonary hypertension in the NICU, in the nursery, over a year, that they can stay well, and then as their lungs grow, they grow new vessels, and it's less likely they would get pulmonary hypertension. So next question, thoughts on riociguat for children. The thing about riociguat is I think it's really neat in that it's a different kind of medication. And on this slide, we talked about sildenafil and tadalafil blocking here, and the riociguat works here. It stimulates this guanylate cyclase. And that's a really exciting and new target. The issue that we don't know yet is that there's been some question in animal studies that riociguat might affect bone growth. So certainly before adding riociguat, we really want to be sure that we're not going to hurt the child, because we do have, again on this slide, we have other options. So the sildenafil and the tadalafil. So we have some work to do as pediatric PH doctors to really be sure this is safe before using it in the very young child with growing bones. So I'm sorry, let me go back. The implantable pump in the stomach it's not an alternative to the central line because it still involves the central line, but instead of the pump being on the outside of the body, it's on the inside. And this has not been used in children yet, but our patients that are on chronic pumps are very excited because then the so-called implantable pump, you would still have the catheter would still go into the central vein and then come out under the skin, but then the pump would be down in the stomach area, and then once every couple weeks or month you would put the medication in. So then your risk of infection would be lower and the ability to go swimming would be much greater. We're very excited about this, and it's just not FDA approved yet for us to use in younger children, but I do think it's exciting, and some of our patients are very excited to consider that as an option. So if a child has been living for 5 years with a VSD and an ASD and pulmonary hypertension, would the lungs ever repair enough for possible surgery? And again, that's one of those questions where is it ever possible? The answer is yes, but are there cases where the pulmonary hypertension, the blood vessel disease is so far advanced that we think the child might live longer not fixing it than fixing it? And so we've seen that when we follow a lot of kids. If you make the wrong decision and you close all the holes, those kids that might do well with a pop-off might do poorly. And so then there are some other options. One is, treating aggressively with some of these pulmonary hypertension medications, redoing the cath, or, depending on the child, either leaving a small hole as a pop-off or a so-called patch valve. So is it possible? Yes. And we've seen we have definitely seen children that's possible. But it's a decision that we take. We really need the very good heart cath information to know that. So let's see. When pressures are decreased with medication and heart function improves, when would you wean the medication and consider the pH resolves? I think that the answer there is it depends on what caused it. So for example, we talked a little bit about babies that are born very early with so-called lung disease of prematurity or bronchopulmonary dysplasia. In those kids, they may be treated, and as their lungs grow and they develop new blood vessels, then the disease might go away, and then we would stop medication and then just monitor. In a child with certain congenital heart lesions, we might do the surgery and treat them for 6 months or a year, and then monitor very closely, and then maybe the medication could be discontinued. In the child that has what we really think is idiopathic or primary pulmonary hypertension, there we think that unfortunately is the disease that we don't have a cure. So even if the pressure's much better, we might take off 1 or 2 medicines, even if the pressures get close to normal. But then we don't. We're a little nervous to completely stop everything, since it is a so-called progressive disease without a certain cure. So I think it really depends on what caused the pulmonary hypertension, but we definitely have some kids that were born prematurely who have been able to wean off of all medicine, and some of our congenital heart patients have been able to do that. Most of our primary or idiopathic patients have remained on their medication. So I think we have time for 1 or 2 more questions. Again, feel free to, whatever you guys, you can certainly ask anything, and that's the nice part about the webinar. So whatever you want to ask, please feel free. All right, it's a little after 7. So any last takers?
In that case, I'm going to jump in here. Thank you so much, Dr. Ivy, for this wonderful presentation and for taking time to answer questions. As I mentioned before, tonight's webinar has been recorded, and it will be available on PH's website sometime in the next month. Things are a little bit hectic with November coming up, but we will have it up on the website as soon as possible. So thank you, everyone, and Dr. Ivy, thank you so much again.
Yeah, thank you all. I'm so glad you joined, and again, we'll do this again in the future, and I really appreciate you joining us. All right, there's sign.
Thank you. Please stand by.